You going to start?
Yeah, we can start now. Hey everybody, my name is Sam Gold, and I'm the president of the Texas McCombs chapter of the Adam Smith Society. And I just want to welcome everyone here to discuss universal healthcare policy here in the United States. So joining us tonight are debaters Ovik Roy and Professor Bill Sage. And along with us, we have Carlos Carvalho, who is our moderator for this evening. And so in addition to us, we are also very happy to welcome the Colorado Boulder Lead School of Business chapter of the Adam Smith Society as well. They agreed to co-host with us, so they're somewhere out there in the attendee space, and I just want to say welcome you guys, and hopefully we can share our Texas spirit and Texas love with you guys. And so without further ado, let's get into this, and let's start with Ovik Roy. He is the president of the Foundation for Research on Equal Opportunity. That is a nonpartisan, nonprofit think tank that conducts original research on expanding opportunity to those who need it, or those who least have it. Roy is also the author of Medicare Advantage for All, a patient-centered plan for universal coverage and permanent fiscal solvency, which is published by FreeOp in 2019. In the past, he has advised 3 presidential candidates in policy, including Marco Rubio, Rick Perry, and Mitt Romney, and he is a senior advisor to the Bipartisan Policy Center. For tonight's debate, Ovik will be taking the side of the free market approach to universal healthcare coverage. Now, his opponent is Professor Bill Sage, Professor Bill Sage, who is a James R. Doherty Chair for Faculty Excellence in the School of Law and Professor of Surgery and Perioperative Care here at the Dell Medical School. From 2006 to 2013, Professor Sage served as UT Austin's first Vice Provost for Health Affairs. He is a member of the National Academy of Medicine, where he serves on the Board on Healthcare Services and the Committee on the Future of Nursing 2020 to 2030. He has written over 200 articles and edited 3 books, including the Oxford Handbook of U.S. Health Law. He was a tenured professor of law at Columbia until 2006, and he has been a visiting law professor at Yale, Harvard, NYU, Duke, and Emory. For tonight's debate, Bill will be debating on the side of government-provided universal healthcare coverage. And finally, the last person up here, he really needs no introduction. He is our very own Professor Carlos Carvalho. He is a professor of statistics here at UT McCombs, and he is also the executive director of UT Salem Center, which their goal is to bridge the gap between data science and public policy. Carlos will be our main moderator for tonight, and so he will be the one hosting. This debate primarily. And as a side note, I've posted the link to Slido in the chat, and that is where we're going to consolidate all of our Q&A. So what you do is you just click on that, make sure you enter your questions. You can upvote others so that we can see what type of questions you guys are asking. And then I will then feed those questions directly to Carlos. And so we can get everybody involved, and so we can get all of our questions answered and make this a full roundtable and discussion. So without further ado, I'll let Carlos kick us off.
Thanks, Sam, and thanks, Ovik and Bill for joining us. We in the Salem Center like to say that, as my jacket says here, there's no solutions, only trade-offs. So hopefully we can address some of those trade-offs today in the discussion. So the premise of the debate, and I think maybe we shouldn't call it just a debate, but more like a conversation on the notion of universal health care. And clearly both sides are going to already agree on the notion of the goal of covering everyone. So universal coverage is something that both sides are in agreement here. So I would start by asking each side to define what they mean by universal. Is that universal means something that is universal insurance coverage? Is universal access to a product without any questions? Is universal as a so what it is that you exactly mean by universal? And relate that to more or less the system that we have today. So what are the aspects of the system that we have today, whether it's Medicaid, Medicare, or private health insurance that mostly provided through employment today? What are those aspects of that you think is part of what it is you see as the ideal place for an universal system? So do we have have we decided who's going to start?
Ovik asked me to start.
All right, there you go. So Bill, you go ahead.
So I'm happy to be with you tonight. I'm teaching 2 classes at UT, though physically I'm not in Texas at the moment. The joys of being able to do everything by Zoom. And I've actually been conveyed by electron to various parts of the country today. So feeling a little tired from the transportation. So we're a week away from presidential election. So Carlos, I'm going to pretend I'm a presidential candidate. I'm not going to answer the question you asked, but I'm going to say what I wanted to say by way of opening. One thing that is interesting from your introduction of my friend Obik is that although we'll have plenty to disagree on about tonight, it appears we both support Medicare Advantage for all. So I guess we're going to end up in the same place. I've been there on Medicare Advantage for all for 3 or 4 years probably. At any rate, so here's what I'd like to do to sort of pose this, and I will take the side of sort of government healthcare. I'm just going to argue that government healthcare is what we've had, just not the right form. So there's often a caricatured dichotomy. Things that are free market are thought to be efficient, but perhaps not fair. Things run by government are thought to be sometimes fairer, but far less efficient. And I want to assert that that is not an accurate description of the US healthcare system. So I'd make 3 opening points about why we should think about this as a public, in other words, government system. First of all, if we think about it as a government system, we can associate principles with it. And I would argue that we have been so pragmatic and incremental and invisible in the way that we have tried to expand health insurance coverage over the last couple of generations that we've kind of stepped back and never rethought or perhaps even thought about what the principles are for a system. And I would maintain that unless we talk about a public system as public, we are not going to talk about those principles. The second point I'd make really is, I think, very clearly illustrated by the COVID pandemic, which is our existing nominally private system fails. What we've discovered in COVID is that our $4 trillion healthcare system doesn't seem to be paid to do the things that we really needed it to do. And the things that we typically pay it for may not always help all that much. Sidelining elective procedures crippled the finances of our healthcare system for several months, kept our healthcare system from responding to the pandemic, and yet did not clearly result in a diminution of the health of America. There may be great things that come from many of the procedures and other services our system provides, but they don't necessarily pay an immediate or even measurable health dividend. So that's 2 things. 1, public systems can be principled systems. 2, perhaps public systems can do what we needed it to do and what we needed a system to do in a global pandemic. Third point is it's public money anyway. We all know that the US pays more privately for healthcare than any other country in the world. Guess what? Even not counting what's been poured into COVID response, the US pays more publicly for healthcare than any other country in the world. And if you count the non-taxability of employer-provided health insurance in this country, the sum total that we pay for healthcare is more than half public money and less than half private money. Not to put too fine a point on it, there's lots of reasons for this, but I often think of the US healthcare system as a giant money laundering operation. Basically, we take a whole bunch of public functions and we lodge them in private organizations so that we don't have to admit in terms of politics, fiscal policy, fears of rationing, and a bunch of other things, that what we really have is a public system. So for me, you put those 3 things together, opportunity to have principles, opportunity to have a pandemic response, and it's all public money anyway if we're really honest about it, or mostly public money anyway if we're honest about it. And I'd rather call it a public system because what we currently have is not a system that is more efficient and less fair. We have a system where gross unfairness and gross inefficiency exist side by side, and if we're not honest with ourselves about what kind of system we have, we're never going to make it better.
Great. And first of all, let me just thank Bill for joining me here. A good friend, an old friend, and sparring partner. And thanks to the Adam Smith Society and UT for hosting this event. I'm a Manhattan Institute alum myself, and so it's always a pleasure to be back doing events that are associated with the Manhattan Institute. My good friend Rayhan Salam, and of course with Carlos at UT as well. I'm going to attempt to answer, if I can remember what Carlos' question. What I think what he asked was, how would you define universal coverage, and then what would be some of the principles you'd associate with it? And I'll respond to Bill's comments to some degree in that format. So first, what I would say is, to me, and to a lot of people like me, universal coverage does not necessarily mean forcing people to buy coverage. And that is often what you hear from people on the left who say, well, it's not truly universal unless everyone is required to buy it. The way I and my colleagues at the Foundation for Research on Equal Opportunity, FREOP, the way we define it is, can everyone afford health insurance? Now, some people may voluntarily choose not to buy it, but can everyone afford it? And the fact is, if everyone can afford it, then nearly everyone will buy it, because health insurance is actually one of those things that everyone wants at the right price. Very few people say, you know what, I really would rather have no financial security if I get hit by a bus, right? Most people want that financial security. And I think that's why universal coverage is an important policy goal. A lot of people, many Republicans will say, well, who cares about universal coverage? What matters is universal access. And if you get hit by a bus, you can go to the emergency room regardless of whether you have insurance or not, and that's good enough. And that really misunderstands the point of insurance. Insurance is a financial product. The purpose of insurance is to protect you from a large financial bill for the cost of your healthcare needs. And while, yes, if you need to get emergency room treatment, if you've been hit by a bus or shot or something like that, you can go to an emergency room in this country and get care. That's true. But what if you have a disability as a result of a car accident? Or what if your son or your spouse has a severe health condition as a result of something tragic that's happened, or even a genetic disorder, where that financial commitment is not one emergency episode of care, but a lifetime of healthcare expenditures? What will you do then? And that insecurity of not knowing how you will finance that care for the average American is incredibly important to address. That's incredibly important for the wealthiest country in the world to address. And so it's largely Democrats who make this argument, but Republicans should make it too. Conservatives should make it too. That in a country that's the wealthiest country in the history of the world, we should make sure that every American has the financial security of knowing that they are not at risk of going bankrupt due to medical bills. So that's an important policy goal. Now the question is, how do you achieve it? And this is another area where there's been a very interesting political dichotomy in the United States that I would argue makes no sense. So you hear, you normally think of universal coverage, that phrase, associated with the left, with progressives. If you're a progressive, you support universal coverage. If you're on the right, you're sort of skeptical of it because that's what the left wants, right? Now, and so there's a certain brand of libertarian or conservative who says to me, well, Ovik, you're not really a libertarian if you're a free marketeer if you believe in universal coverage. And I say, you know what? Let me ask you this. And we can't do this since we're not doing this in auditorium, I can't do this in real life. But I'd ask those of you watching and listening, raise your hand if you believe that in order for every American to have a job, the government needs to take over the entirety of the economy. I think most of you wouldn't raise your hand if you're generally involved in the Adam Smith Society. I think most of you wouldn't raise your hand if I asked you, raise your hand if you think that for every American to have a smartphone, the government needs to take over the smartphone industry, right? So why is it that we believe that for every American to have affordable health insurance and health care, we think the government has to take over the healthcare industry or the health insurance industry? That isn't necessary at all. In fact, there are plenty of countries that show that the private sector can deliver affordable insurance products. And that doesn't mean a completely unregulated system. There are often regulations around insurance and the price of healthcare services and things like that. And we can get into some of that, particularly when it comes to monopolies in healthcare, of which there are many. And you have to either regulate those monopolies like utilities or try to promote competition wherever you can. But given those constraints, you can have universal coverage in a free enterprise system. And here are some of the ingredients you have to do it in the most market-oriented way possible. One, you have to really have a system in which the financial assistance you're providing is geared to the people who actually need it. And that is not what we do in America. So as Bill rightly said, we subsidize health insurance and healthcare in America per capita way more than any other country in the world, which is a big part of why healthcare is so expensive in America, because we subsidize it for everyone, rich or poor, healthy or sick, and nobody has an incentive to really care about the cost of healthcare unless you're uninsured. Hospitals can charge whatever they want. Drug companies can charge whatever they want because they know that the taxpayer is on the hook for the bill at the end of the day through government funding, through the government middleman. That is a huge problem. And if you look at the smart private sector oriented universal coverage countries, they're much more efficient about that. They target their subsidies to the people who really need the help. You and I, all of us who are on this call today, we're all paying taxes so that Mitt Romney and George Soros and Warren Buffett can have government subsidized health insurance through Medicare. That makes absolutely no sense. We should not have a system where lower income Americans pay taxes so that billionaires and millionaires, to quote Bernie Sanders, get government subsidized health insurance. We should be kicking them off government subsidized health insurance and only subsidizing those who need the help. That's number one. Number two, you have to have a system in which you do everything possible to make healthcare affordable. Now, in the single payer systems that Bill is more favorable to than I am, that's strictly regulated through prices. There's a government fee schedule of what a knee surgery costs and what a drug costs and et cetera. Now, you can keep a lid on costs that way, but you often end up with restrictions on access, and you often find that the availability of certain healthcare services is not what it could be. The basic stuff you can often do through a single payer system. And there are advantages to a single payer system compared to the worst of both world system we have in America. We don't have a free market system. We have like a crony capitalist system in which we subsidize the healthcare industry massively, but do not force them to either compete or be accountable for the prices they charge. The other approach, the approach that sort of I would contrast to the single payer approach, is one in which wherever possible, drug companies, healthcare providers, doctors, hospitals are competing for your business as a patient and competing on price and quality and value. And where natural monopolies form, then regulate like utility if you absolutely have to. But use the antitrust powers that the government has to rebuild and reconstitute and enforce competitive practices wherever possible. We do not do that. We have this perverse form of libertarianism in America where antitrust action is considered government intervention, but sitting by, watching idly by as regional hospital monopolies raise their prices by 10, 15% a year, and we do nothing about it because they're monopolies and they can do whatever they want. We're okay with that. And that shouldn't be the case. So that's a really important thing to do. If you want to have an affordable healthcare system in a market-based system, you've got to be very unsentimental about monopoly power and how to rein that in, either through more pro-competitive rules or through regulating those monopolies like utilities where necessary. And then the final thing I'll say is that the real disadvantage of a single payer system is that there's no choice. If that single payer system decides to do something that you don't like, if you don't like the insurance package you get or the benefits you get or the access you get, you have, in most cases, not all, but in most cases, no alternative to that single payer system. There are some countries that do. So for example, Australia has a system in which there's a single payer. It's kind of like our public high schools or public education system where, you pay the taxes for the public school system, but if you want to buy private insurance and opt out, you can do that and just pay the extra money for it. So there are systems that create that escape valve. That's not the only form. But in a lot of countries, there basically is no meaningful private insurance market. They really go out of their way to basically abolish or limit the existence of private insurance. And that's certainly what Bernie Sanders and the advocates of Medicare for All support here. They support the abolition of private insurance on the premise that private insurance is fundamentally immoral. And so what is really important, and the reason I bring that up, is that what I really want, and what's really, if you really want to have the best kind of healthcare system, and the reason why a market-based healthcare system is better, is you want that choice among not just the doctors and the hospitals and the drugs, but among the insurers. You want insurers competing for your business to figure out who is going to do the best job of giving you that financial security and offering you the coverage that's best for you and your family and your friends. And a single payer system does not is tempted to abolish that market if not in name and in law. And so when you have multiple choices, if you look at Medicare Advantage, why is Medicare Advantage so great? If you're a senior and you're in Medicare Advantage right now, you can choose among 20 different private plans in your area that are competing for your business every year, every day. And if you really hate them, of course, you can go to the traditional single payer version of Medicare, the fee-for-service program. If you want, you could call it even the public option of Medicare. But here's the interesting thing. Every year, private Medicare Advantage plans gain market share over traditional government-run Medicare. Unsurprisingly, because the private plans are more popular, they're more cost-effective, and they do a better job of providing the best health outcomes compared to traditional government-run Medicare. And so the Congressional Budget Office actually predicts that by the end of this decade, more than half Americans enrolled in the Medicare program will be on Medicare Advantage, private plans, not on the fee-for-service traditional system. Last thing I'll say, and then I'll kick it back to Carlos and Bill, is Bill mentioned this point about how we can't, a private system or a free market system can't handle a pandemic, and that's why we have to have a government-run system. Well, two of the countries with the worst mortality per capita in Europe are Italy and the UK, which have single-payer health insurance systems, and in the case of the UK, a fully socialized healthcare system. So it's far from clear that having a single-payer or socialized system inherently leads to a better performance in the pandemic. A lot of other factors seem to be involved. Singapore has done well with the pandemic, which is a more market-based country. So has Taiwan, which has a single-payer or Medicare for all kind of system. The health insurance system has not really correlated to performance during the pandemic. And I lied. One last thing I'll say is that Bill said that there's no principles involved in a free market system. Only government-based systems have a principle underlying them. I would strongly disagree with that. I think there are a lot of principles involved in a market-based system. The principles that you, as the patient and the consumer, have the choice of how you engage with the healthcare system, which doctor you choose, which hospital you choose, which insurance company you choose, and you can spend your healthcare dollars in the way that you see fit. That's a very, very important set of principles that a single-payer system diminishes.
So can we debate this?
Yes. So, but before I send it back to you, Bill, let me ask you the following question, because that's something that the audience already pointed out here, and it goes for both. Before you can respond to Ovik, but also tell me about a place, countries out there that might have something that you think is closer to ideal, and what are the examples that we see of something working as you think is closer to ideal out there?
So that's a great question, and I spend an entire hour and a half of a health law and policy class talking about it. Let me respond to some of Ovik's, but then we can definitely come back to that. International comparisons are fraught. The Commonwealth Fund publishes a report called Mirror almost every year that compares on a variety of parameters systems across the board. And it's very interesting in terms of where different countries and different systems perform better or for worse. But always remember that the US healthcare system is functionally twice as expensive per capita as any other country. And so, we should at least be expecting 1.5 times as good results. And I don't think either Ovik or I would claim that you get them from the system. Let me make a few points going back towards Ovik, and these are all, I'm going to be extremely blunt because I tend to be, particularly with audiences who hear what sounds like a technical debate and think there's more expertise associated with it than really exists. So Ovik, if I give you one piece of advice for public discussions, please don't quote the CBO. The Congressional Budget Office scores are umpires' calls in a legislative game, and by and large, they are inaccurate and often destructive. And
I agree with you.
I know, I figured you'd agree. And I published a piece with Tim Westmoreland a couple of weeks ago, came out in the Journal of Law, Medicine, and Ethics, that shows the fiscal politics of Obamacare. And it confuses people because people think those numbers are real numbers. For example, Ovik and I would both like to see a Medicare for all system. The CBO will tell you that a Medicare for all system will add roughly $1.5 trillion in taxes to the country's bills and add about $1.5 trillion in healthcare spending to the size of government. And Ovik and I know that that's ridiculous, that the money is starting and ending in the same places and going for the same things. But we shouldn't govern our decision about a Medicare for all system by what the Congressional Budget Office scores it to be. So it would be really good just to get that out of the discussion. We can talk about real costs, but we shouldn't be talking about CBO estimates. These are stylized. Second point, I'm just going to be really blunt about this. No, it's not a single payer health system that's immoral, and it's not private insurance that's immoral. It's in our existing healthcare system that's immoral. I mean, we have a grossly inefficient and grossly unfair system that perpetuates all sorts of accidental and deliberate racism and discrimination, and we can do far better. And I think we both, Ovik and I, would agree on that. And I am often calling very directly to the medical profession to step up. And job one for me, for the medical profession, is for doctors to say, yes, our current system is unethical. And that's something they really struggle to do, but there's lots of reasons why they should agree with that statement. A couple other things. It doesn't really make much sense to me to be talking about insurance. Almost none of the insurance companies involved in US healthcare bear insurance risk. They're claims processors and administrators. They do it for government. They do it for self-funded employers. If they do bear insurance risk, they have various public and collective sort of redistributive arrangements that cushion that risk. And that's one of the big problems in the system, which is that basically the people you think of as, buyers in a buyer-seller system are really not buyers, they're intermediaries, and by and large, they get out of the action. And if you can find insurance companies that actually do pay attention to cost. If you look at the industry as a whole, it takes a cut of the revenue going through it, and it has very little incentive to preside over a radical decrease in that revenue. And that's just a fact. But we talk about insurance as if it's something else. I love Medicare Advantage. One advantage Medicare Advantage has is the Medicare Advantage plans are capped at Medicare fee-for-service rates for most providers. And that is a huge advantage that does not come from market competition. It comes from the fact that Medicare Advantage plans are embedded in a regulated public system. And so we shouldn't be confused about that. I don't love the NHS, though I do value the social solidarity and pride that goes with the UHS, but I do like movies. And when I talk about the NHS, I tend to think of a lot of aspects of the NHS as the Truman Show. It's all very pretty, it all works quite well, but it's highly orchestrated and very directed. When I think of the US healthcare system, you know what movie I think of? I think of Jurassic Park. And somehow in 1965, when we passed Medicare, and in the post-war period, when we subsidized private employer-based insurance, somehow we thought those dinosaurs couldn't reproduce, and guess what? They did. And the system we now suffer with is Jurassic Park out of control, and we can do better.
So, Carlos, your kind of original question was what countries should serve as models to the U.S. And to that, for the audience, I'll recommend that they visit our website, freeop.org. We have a study that we've done, a very large study that's related, or relevant to what Bill was talking about in terms of international comparisons. It's called the World Index of Healthcare Innovation. We actually look at the 31 highest income countries in the world that have a population above 5 million and compared their healthcare systems. Not just the US, Canada, and UK, and some of the OECD countries that you see in these lists, but also countries that are not in the OECD and therefore are not often in standard academic comparisons, such as Singapore and Taiwan and the UAE, all high-income countries that generally are not in these comparisons. And the top three performing countries in our system, and we looked at quality, we looked at science and technological innovation, we looked at choice, and we looked at fiscal sustainability. Those are our four dimensions in which we ranked all these countries. Number one was Switzerland. Number two was Germany. Number 3 was the Netherlands. And all those 3 countries have in common the fact that they have universal health insurance using private insurers, not a government-run system. I mean, yes, the government is involved in the regulations and particularly, again, some of the things around monopoly pricing. But those are all systems where the insurance is delivered by private entities, not by a government agency. And so those are some of the countries that I would recommend as models, particularly Switzerland, because what's really unique about Switzerland is basically they have what we might call Obamacare for all or Medicare Advantage for all, in the sense that everyone chooses their own health insurance plan. Those health insurance plans are bracketed by a certain set of regulations, but the financial assistance that you get as a Swiss resident is very high if you're poor. If you're poor, basically your premium is paid for entirely by the taxpayer, but that premium assistance scales down as you go up the income scale very gradually. So if you're upper income, and let's call it, if you're in the top half to 2/3 of the income spectrum in Switzerland, you're not getting financial assistance for your premium. And that's how they've achieved universal coverage in Switzerland. So their public spending per capita is less than half of what public spending per capita is in the US, and yet they have universal coverage. So that's a system that I think is one that we can look to as a model, because Obamacare and Medicare Advantage are, in a sense, versions of the Swiss healthcare system that are already embedded in the US. So it's not that hard to imagine a transition from the system we have, the Jurassic Park that Bill described, to something that's more coherent, that looks more like Switzerland. I want to be clear, I don't support Medicare for all in the sense of the way Bernie Sanders means it, of a government-run system. I support Medicare Advantage for all. I support a system in which everybody has coverage, but that coverage is delivered by private entities. And yes, there's a spectrum of what counts as a private entity in terms of the regulations and things like that. But for me, it's actually a very important fundamental principle that it's the private sector that's more accountable to you as the patient and the consumer, relative to a bureaucracy that can get captured by special interests that is not necessarily going to be responsive to your interest as a consumer, as a patient. That's an incredibly important line that I would draw between a single payer system like what gets called Medicare for all and Medicare Advantage for all. So another country that I would mention as a model for the US is Singapore. I've written a lot about this at freeop.org. Singapore is a very interesting model that's neither a true market system or a true single payer system. They have single payer catastrophic coverage, but everything short of that catastrophic insurance plan is paid for through health savings accounts that are universal. So what Singapore does is they take their equivalent of our Social Security taxes that we pay with our paychecks, and they deposit a portion of those in a health savings account that you control, and then you can pass on to your family members if you want to. And you use that to pay for your everyday non-catastrophic healthcare expenditures. That system has worked very well. Singaporean spending on healthcare as a share of GDP is like a quarter, a third of ours, basically a third of ours, or like 6% of GDP, whereas we're at 18%. And their public spending is even lower because, of course, it's not entirely public spending that drives healthcare. So that's a really interesting system, just not in the sense that that should be a model for the US, in the sense that we can just flip a switch and turn our system into the Singaporean system. But, and again, we describe all these systems extensively at wihi.freeop.org, wihi.freeop.org. The Singaporean system is a good illustration of how a more consumer-driven healthcare system, where HSAs are a backstop and where you supplement the value of that HSA for low-income people who otherwise can't afford to save on their own, that system works really well at providing that consumerism into healthcare and driving quality and value. But Switzerland, in particular, I think is the best, most proximate model to what we could achieve here in the US. And our proposal for health reform that we call Medicare Advantage for All is about how you take our gamish of a system and make it more like Medicare Advantage. How you take the employer-based system, and instead of a system where HR bureaucrats at Google and General Motors are buying insurance for people, give that money to the worker to shop for the coverage that the worker wants. We do that. We also convert the Medicaid system. You know, Bill talked about the inherent racism in our system. Well, there's nothing more racist in our system than Medicaid, which we underfund and have structured in an incredibly broken way so that low-income people in Medicaid don't have the access to care that people with private insurance have. So if we had a system in which people who are low income had the same quality of coverage that higher income people have, buying coverage the way, say, even in the ACA, people are able to buy coverage if you're above the poverty line. That would be a significant improvement. That's something that we do. We basically enable people to move away from Medicaid to a more private-based system like Obamacare, but a more choice-oriented version of Obamacare, so that people can shop for the coverage that they want at a price they can afford.
Bill, you want to respond to something?
I triggered Bill there with my Medicaid comments.
On the Medicaid, yeah, and I've turned into an advocate for Medicaid as I've watched it evolve over the years. And Medicaid is now a larger program than Medicare by enrollment, and a comparable program almost by cost. Medicaid, to caricature it only a little bit, was appended to the Medicare legislation in 1965 in the hope of killing it, thinking that most Americans, although they might support social insurance for all elderly, would not support a welfare insurance program for the poor. They were wrong about that. What's interesting, I think, about Medicaid, and this is a point I learned from Sarah Rosenbaum and Lauren Taylor in a piece that they wrote a couple of years ago, is that some of the great successes of Medicaid are that because of the population it covers and the services it covers, it doesn't try to act as insurance. It has set up a system of service delivery that could definitely be improved, but in a lot of ways, the great strength is that that sort of financial protection that Ovik accurately describes as an idealized insurance market is not going to extend to the health-related, not all medical services that poor people need and want. They cannot participate in a traditional insurance relationship. And Medicaid's actually been enormously successful, and I think we should stop bashing it.
Yeah, so I totally disagree with that. I think Medicare, precisely for the reasons Bill described, it was an afterthought slapped on to the Medicare legislation in 1965, not well designed. As a result, today the system is broken. Basically, the way Medicaid works is it's nominally run by the states, but mostly funded by the federal government. And the federal government says to states, here's some money, go cover your low-income and disabled populations with Medicaid. And states are not allowed, because of this congressional statute, they are not allowed to control costs in any way other than paying doctors and hospitals gradually less over time. And so what's happened over the 55-year history of Medicaid is that gradually, because states can't issue treasury bonds to have their deficits funded by China, they can only basically cut costs, or teachers will have to get paid less, or policemen will have to get paid less, or schools will have to get underfunded. So what Medicaid programs have done year over year is dialed down gradually what they pay doctors and hospitals for the same amount of care. And as a result, in places like California and New York and New Jersey, where the Medicaid programs are the most extensive, for example, to get primary care, for every dollar that a private insurer would pay a primary care doctor, Medicaid pays 29 cents. Now, there are certain doctors who are willing to take that 29 cents to care for those patients, but it's actually, in a sense, worse than charity care, because if you're uninsured, you might pay the doctor more than 29 cents on the dollar to get that care. So as a result, a lot of people who have this card that says that they have insurance, and as Bill said, they do have that financial protection if they do get hit by a bus, or they get shot, or they have some seriously large medical bill. But for that everyday medical care, they don't have good access to it. And a lot of low-income people have chronic health conditions, heart disease, diabetes, high cholesterol, where maintenance and care for those chronic conditions really matters, let alone mental health issues. And so access to primary care is really important. And so, as Bill said, the cost of Medicaid is incredibly high right now. It's over about $500 billion a year, all told. And so, yeah, you could spend more on Medicaid. In fact, the way we do it was we say, instead of spending more on a broken system that's not serving those patients well, let's subsidize coverage for those individuals in the private market. So again, they're not exposed to the cost of coverage. That cost would be paid for by the taxpayer. But the difference is, unlike the Medicaid system, where they can't get access to primary care, in the Affordable Care Act's marketplaces or exchanges, in the reformed version that we propose, they would have very broad access to physician care and therefore better health outcomes.
So Ovik, I completely agree with Ovik on one point there, but for some reason he's ignoring two others. So I completely agree that the basics of Medicaid financing make no sense. But as Ovik would tell you, the basics of employment-based health insurance make no sense because employment grows at the rate of the general economy and healthcare grows faster than the rate of the general economy. That's not actually a well-designed system. The problem with Medicaid, as everyone knows, is that because, as Ovik points out, states at least aren't supposed to borrow money from China, though some of them succeed in doing that. When state tax receipts get worse in an economic depression or recession, that's when Medicaid enrollment goes up because more people are poor and more people qualify. And as a result, the basic financial model of Medicaid is, as Ovik points out, fundamentally flawed. And that's why the federal government does keep having to pour more and more money in. I also agree with Ovik that there is a terrible tragedy, a true moral tragedy associated with the state-based funding of Medicaid, which is that state legislators every single month are confronted with the trade-off between the two sources of human capital formation in the United States, which are health and education. And every state legislator finds him or herself in the situation of having decided to cut education to fund health or having to cut health to fund education. And that is absolutely morally wrong. But the two things that Ovik for some reason is ignoring, first of all, is that the Medicaid program is two programs. It's a program for generally young, generally healthy, generally employed people who just don't make enough money for their employers to support health insurance as part of their compensation package. And then there's an entirely different Medicaid program for the elderly, for custodial care and home care that's custodial in nature, for the disabled, for the blind, et cetera. And these are two fundamentally different programs, and you can't talk about Medicaid and mix them together. You have to talk about each of them separately. And finally, Ovik, for some reason, when he talks about cuts in doctors' pay, all of which is correct, leaves out the fact that at least for the younger, healthier, larger number of Medicaid enrollees, in virtually all states, those enrollees are in managed care plans, which are Medicaid managed care plans that are analogous, though far from identical, to a Medicare Advantage plan. So in point of fact, they do get to go to a primary care doctor, and that doctor does get reasonably paid, and it's not the fee-for-service Medicaid rate.
So, if there's a government contracted private monopoly, that's not a market. And that's what Medicaid managed care is in most states. It's like the fact that there's basically one company that makes an aircraft carrier. That's not a market. So I think it's important, just because there's a private company involved that's publicly listed on the New York Stock Exchange doesn't mean that it's not a single payer or a government run system.
Is defense contracting a market?
No, it's not. That's what I'm saying. I mean, it's
competitive bid. So competitive.
Well, if there's a true competition, you could call it. There's a market for the government contracting of the service. If there's like 10 bidders, yeah, like there is a bit of a competition there, but there's no competition at the patient level, right? The patient has no choice. The state of Arizona says we're going to contract with Centene, and then Centene is your managed care provider in your Medicaid program, and that's it. If you don't happen to like Centene, tough luck to you.
How much turnover is there in an MA plan? I think you and I would agree that one of the great advantages of the Medicare Advantage structure is that there's very little turnover. There is choice at the margin. But
that choice at the margin really matters, Bill, because it means that as a company, as an insurer, you are accountable. You know that, yes, people are sticky and they'll stick with you. But if you're really terrible and people have a better choice out there, whether it's a better choice in customer service, a better choice in price, they're likely to go there. And I want to use that to build on a point that you made that I really think is worth expanding on, which is, that the employer-based market is employer-based insurance system is not a market either. The idea that an HR bureaucrat picks your health insurance is not a meaningful improvement on a government bureaucrat picking your health insurance. And one thing that I really want to hammer this point home, because if Joe Biden is the president, and you'll hear a lot of Republicans next year saying things like, well, those Democrats, they want to take away your employer-based insurance, which is just so wonderful and worth bear hugging and protecting like a 2-year-old. When in fact, the employer-based system is almost singularly responsible for the runaway healthcare inflation that we've had since 1945. It is a system that absolutely needs to be reformed. And our plan at FreeOp is about that. It's about converting the employer-based system into one where the worker picks his own health insurance. Maybe the employer helps fund, gives you the money to help pay for the insurance, but you're choosing your own insurance that the company itself is not organizing for you in the form of traditional employer-based group insurance. That's an incredibly important reform that if without which the current system that we have is not long for this world, because at a certain point, people are just going to get sick of the 15% per year price increases. And they're going to say, you know what, I'd rather have a government run healthcare system, because that's going to be an improvement on the fact that at this point, you have people paying 40% of their income for health insurance. I did a study recently that showed that the average household today gives a bigger share of their income to the hospital industry, not the healthcare industry, the hospital industry, than they send to the Internal Revenue Service in taxes. That's how bad the high cost of healthcare is in America. It's totally unaffordable, totally unjustifiable. And if those of us who want a market-based system don't move the employer-based system into one in which workers choose their own health insurance, there will not be private health insurance for the non-elderly population in this country. And that's an incredibly important.
Let me try one thing here that I think.
Go ahead, Carlos, because we haven't let you talk at all.
No, I just want to try something that I think help us anchor a little bit the source of disagreement. I mean, clearly we both of you agree that there's incredible problems in the system that we have today. It's not second best, not third best. It's like fifth best, and it's I like the Jurassic Park analogy. It's a good one, that somehow the dinosaurs became what it is today, running around. Let's compare that to education. As Bill brought up education as this other important source of human capital formation, right? And the education system, we have this sort of almost monopoly on. And the reason I bring it up is because there's in the discussion there's a lot of distinctions between what's the payer versus the provider. And that gets confused and so on. So why even have those two notions if we can, I think in Bill's view of the world, you could have something that, is your view a view where doctors work for the government? They're going to be just like we treat the public school system, where this thing here is a government-run institution. And sure, maybe some of us can go outside and buy and go to our own private schools, or no, you still think that this is something that we allow that system to have some notion of, no, doctors don't work for the government, they work for their hospitals or whatever, and they get paid from the government somehow through whatever scheme we come up with.
Yeah, so the latter of those two choices. I mean, at the end of the day, I think Ovik and I have some good points of disagreement, but at the end of the day, we're both going to support Medicare Advantage for all, and we're both going to support certain changes in the employment-based system. What I'm saying is that we have to stop complaining about bureaucrats, whether they're HR bureaucrats or they're government bureaucrats. We have to stop conjuring images of something as being government run versus private, and realize that what we have right now is the ultimate special interest capture. We have a healthcare system that we half a century ago handed over to the organized medical profession and every other industry that could leverage the authority of the medical profession for their own financial advantage. And we have created that medical industrial complex that was hinted at in the years immediately after the passage of Medicare, though in a slightly different form. I mean, we really do have a system that has, in many ways, the worst of every possible feature. And COVID does emphasize this. It's not that we get nothing for $4 trillion, but we certainly didn't get a COVID response. And Ovik is quite right that we can't correlate in a neat way features of particular countries with their COVID responses. But we can say that, when all those really well-trained nurses and physicians and others should have been mobilized with their skills and their ethics and their personal commitment to assist with COVID, nothing happened, because the systems that are in place for paying those people don't pay them for treating the Medicare patients and the Medicaid patients for the COVID-related conditions that were the crisis in March and April and are becoming the crisis again. And the public health system that should have been there to really do surveillance and response and testing and monitoring and innovation has been so underfunded for decades to centuries that it really wasn't there either. And that's the point. We have a system that gives us the things we ask it for, but we can't, we shouldn't just decide that the system also will provide the things that we do know we desperately need, because we haven't set up that system. I could have actually prevented, by system design, about half of the gross mismanagement associated with COVID just by acknowledging the system that we have is a system that does the things that we allow them to charge for, and putting in place the billing codes that would have constituted a real COVID response. Instead, we pretended we had a public health surveillance system that really doesn't exist because we haven't funded it and we haven't designed it and we haven't supported it. And we're in deep trouble. But I don't think we need to talk about COVID particularly. We need to understand that, in light of what we have failed to do in COVID, there's even greater urgency attached to the needs of reforming the healthcare system overall. I also just want to say one quick thing on Ovid's point, which I agree with, about the private employment-based system. So let's put this in the context of a business school audience. So if we were to sort of talk to the McCombs audience or the CU audience and ask, where do you want to work? They'd name all these great companies, many of them American, not all. And all of those companies are fabulous at their core businesses, because that's why you want to go work for them. And all of those companies are crappy healthcare purchasers. And trying to figure out why is one of the great enduring mysteries of American health system analysis. And we could both, though we don't really need to, speculate about the reasons, but it is just astonishing that in what you would expect to be the sharpest point of buyer-seller competition in the healthcare system, the buyer is asleep at the switch. And that's not the government. That's all these great companies that you all want to go work for.
Well, I'll just have to totally disagree with that, because the reason why employers are terrible at buying health insurance on your behalf is because their interests are different from your interests as a worker. Their interests are in retaining you by diverting your wages into health insurance, where there's a massive tax subsidy, as we've talked about. It's excluded from taxable income if somebody provides you health insurance. If they provided you that money in the form of wages, it would be taxed by the federal government and by Social Security and by Medicare and by your state if you don't live in Texas like we do. And so you pay all these taxes on that money. So that has created a powerful incentive, first of all, for your wages to be spent on health insurance rather than other goods and services that you might value. And second, it completely divorces you, the consumer, from the value and price of the health insurance that's bought on your behalf. So those are massively powerful federal government-run incentives for you, for there to be healthcare inflation and for the quality of healthcare to be bad. As Bill said earlier, health insurers in the employer-based system have an incentive for prices to go up, because if they're going to get a 5% cut regardless, a 5% cut of a bigger number is a bigger number for them. Contrast that to the more individually oriented consumer-driven markets like Medicare Advantage and the Affordable Care Act's insurance exchanges, where there's vigorous competition, particularly in Medicare Advantage, for your business as a consumer. The Medicare prescription drug benefit is another example, where there's vigorous competition on price. And if your premiums are too high, you're not going to get the business. Seniors are going to go to someone else because they are price sensitive, and it's their money that they're going to keep if they go with a less costly plan. So that's an incredibly important element of all this. It's not a mystery at all. It's quite obvious why employer-based coverage is so terrible and so expensive.
Well, it's a contributing factor.
So I want, well,
not an explanation. But so Ovik, what Ovik's saying, and it's part of his plan, it's one of the things in the plan that sort of helps the CBO score of it, but we shouldn't confuse ourselves. is that he would like to significantly reduce, if not eliminate, the non-taxability of employer-based coverage. So Ovick believes that. Guess what? I believe it too. Guess
We don't
what?
eliminate it.
Virtually,
we don't eliminate. We just cap it. We don't eliminate.
Well,
we reintroduce a version of the Cadillac tax.
This is what in the ACA was called the Cadillac tax.
Yeah.
And so Ovick would significantly reduce it, and he would argue that would make employer-based coverage work a little better, and I would agree with that. But a point that's important for the audience is that every single health policy expert, except perhaps at the very extreme of some political spectrum, also agrees with that. We would all love to cap or eliminate the non-taxability of employer-based coverage, but in the real world we inhabit, that is a huge political reach.
That's true.
Let me ask you a question from the audience here, because that's one that I think it speaks about this point in a more focal way. We're here probably with if I quote Nate Silver, with an 80% chance that Joe Biden is our next president. Okay, and Joe Biden has a public option plan in front of us, which is it's a version of Medicare for more. I think that's what they say it. I'm not sure. And how would you contrast, under your different views of what an ideal system would be, what the plan takes us, and how do you think, how feasible you think those steps are going to be to be taken, and how much better or worse will be as a result of that?
Well, first of all, it's very, very unclear what Joe Biden means by the public option. So traditionally, among health policy experts like Bill, a public option means there's a government-run insurer, like the traditional Medicare program we were talking about before, that has a fixed fee schedule, commonly done as a multiple, actually, of Medicare's rates, either 100% of Medicare rates or 125% of Medicare rates, something like that. And that as a result of basically paying less money to hospitals and providers. And again, maybe that's right. Maybe they should get paid less. Maybe they're overpaid in the commercial system, but they'd be paid less. And as a result of being paid less, the insurance would cost less. And then the public option would be a more affordable option for consumers than what they get from their employer. That's the economic theory behind the public option. There's, of course, people who don't care about the economic theory, for whom it's just, I hate the private sector and I want there to be a government-run insurer, and that's what they like about the public option. But among economists who care about the public option, it's really about the fact that there are lower prices, and to some degree, there's an argument that a public option has lower administrative costs, so I find that to be very implausible, and that's basically the idea. Now, here's the thing. The actual public option that Joe Biden is campaigning on, it's vaporware. There's no specification as to what rates this public option would pay. For all we know, the public option in Joe Biden's plan would pay exactly what the private insurers pay. That's what some of the state-based initiatives to have a public option have done. Basically, so Colorado made this big news. We're going to have a public option in Colorado. And what ended up happening? The public option in Colorado isn't actually a government-run plan. It's issued by private insurers, and basically there's some sort of negotiation around what exactly that those private insurers would pay. That's pretty similar to what that they pay already. So that's basically a public option in name only, or PINO, we might call it. And similarly here in the Joe Biden case, Joe Biden hasn't really campaigned on saying, hey, I'm going to have a public option that actually pays Medicare rates. You know why? Because if he did that, the hospital industry and every doctor in America would be voting for Trump, even if they don't like Trump. And he's aware of the political fallout that would come, the political resistance that would come from a real public option that would actually have any economic or fiscal utility. And I bring all this up to say, Joe Biden is not going to be able to implement a public option if he wins, because the Senate is going to still be roughly split 50-50, maybe 52-48, something like that. And he's just not going to have, if he hasn't campaigned on it, he's not going to have a mandate to implement it, given how disruptive would be, maybe for the right reasons, but still it would be super disruptive to hospitals. And this goes back to a question you asked earlier, Carlos, which is, well, what about choice of providers? One argument that the pro-single payer Medicare people will make, and it's a fair argument, is that, well, under traditional Medicare, you have complete choice of providers. You can go to any knee surgeon you want, regardless of how much they charge in the private system. That's true. In Medicare Advantage plans, they actually have networks where the highest cost, low value providers are often excluded from your choice of provider. So in a sense, you have more choice with that single payer system. But as a result, if you look apples to apples between what Medicare, traditional Medicare, and private sector Medicare Advantage charge, the premiums are often lower in Medicare Advantage because those networks are more actively designed. And the last point I'll make, just to respond to something that Bill said, was, the CDC, this we don't have a good enough public health surveillance system, and that's something the government should do. The CDC has had a public surveillance system for a long time. It just hasn't been up to the task when we need real-time data. You could argue that's about underinvestment. It's actually more about antiquated software. And what has happened as a result of the CDC's failings is HHS stood up in a matter of weeks a new system, largely built by Palantir and a couple other tech companies, that does aggregate real-time data into a much better surveillance system. So this is an example of where the private sector innovation can really play a role. And that's not just true in these public health COVID pandemic situations. It's also true in health insurance and healthcare, which is why, wherever possible, we should create room for that kind of innovation and leave it outside of the bureaucratic process, whatever Bill thinks of the bureaucratic process.
So
Bill,
let me just comment on a couple of pieces of that. Leaving the COVID public health response aside, except just to add, if you're looking within the established medical care system, doctors, hospitals, et cetera, at information systems, in healthcare, all those organizations have collected all the information they've needed to collect in order to get paid. Full stop, end of sentence. So Ovic can be right about the established public health surveillance system with information adequacy. We have parallel information inadequacy in the lavishly funded medical care system. And I know he agrees with that. It's a fact, but it's something people don't really know. Everything he said about the public options, I think, is a great description. I completely agree. Let me just highlight a couple of things that people might not have heard. First of all, implicit in the way he described the Biden plan, and by implication others, health system redesign is a terrible campaign issue. The only thing that's good about it is if someone else has a plan that you can criticize. But the fact that it's hard to campaign on doesn't mean you can't govern on it. You still have to try to govern on it. And that's what most of us who aren't particularly partisan in anything, when we think about health system redesign, we just hope it won't be a big campaign issue, because we don't want people making promises that we think would be very foolish for them to keep. And we don't want people walling off, options that we think should be retained. The other thing that's worth understanding from Ovic's description, which was, I think, extremely accurate, is that the meaning of the public option varies by time and constituency. And for some people, especially back in the 1990s, where the image was tight network managed care, the public option was, with the traditional Medicare plan, a way that people felt they'd still be able to keep their doctors. Over time, people have gotten resentful of large private insurance companies, and just think, if you're resentful of large private insurance companies, that maybe having government there will do a little bit better. People who live in rural areas or in areas that have only had, say, one exchange marketplace plan in the Obamacare marketplaces might think a public option will give them some alternative or give them some organized source of coverage if for some reason that plan is no longer available. It's a term that means different things for different people, but basically it's just about reassurance, not reinsurance, just feeling reassured that whatever they're most afraid of would somehow be somewhat protected by having the public option. And I think, considered in that light, anyone who becomes president who cares can create some type of public option. That said, I'm much happier with, a Medicare Advantage for all. I've been very much on that side for quite a while now.
So both of you seem to agree on that. So what are the steps that in terms of that are needed to be taken in order to expand that, and how costly? What are the trade-offs that we face in putting that forward? Who's going to pay? Who's going to, is the doctors are going to get paid less as a result? Is the hospital system they're going to basically do away with their rents? And for us taxpayers, what is that going to cost?
So in our system, and Bill may have a different vision of how to get there, but in our version of Medicare Advantage for All, and by the way, there's now actually a bill that's been introduced in Congress, both in the Senate and the House, based on our plan called the Fair Care Act. The Senate lead sponsor is Senator Mike Braun of Indiana, and the House lead sponsor is Bruce Westerman of Arkansas. And we've estimated that plan would increase the number of people with health insurance by about 9 million, because it doesn't mandate coverage. It doesn't get all the way to 100% everyone has insurance, but everyone would have financial assistance to buy insurance that they could afford. And how does it reduce costs and reduce the deficit while expanding coverage? By attacking these problems of high cost. So it would eliminate eligibility. It would be more progressive in the sense it would means test public assistance. So we eliminate Medicare eligibility for people who are in the top 1% of lifetime earnings, people whose lifetime earnings exceed $10 million. We do some things around the employer-based system, not just capping the exclusion from taxation, but also requiring all new companies founded after 2021 to, instead of buying group insurance for their workers, if they want to have the tax deduction, to give that money to the worker in the form of a health savings account or a MediSave account, as we call it in the plan, like Singapore, to buy their own coverage. And we also, as I mentioned, migrate the able-bodied Medicaid population into private insurance. Bill rightly said that Medicaid has a lot of different elements to it. Insurance for poor people is one of them, but it also does things for the disabled and other things that are not germane to what I've just described, and we leave those intact. So that's a very short example. I know we're running low on time, but what I'd encourage you to do is, if you go to our website, freeop.org, the first article right now on the homepage is called The Fair Care Act of 2020, Market-Based Universal Coverage, and that leads to a lot of other links that describe our plan and our approach.
Bill? Medicare Advantage for more.
How much time do we have, by the way? I'm just curious.
A few more minutes, I think. You have the last word.
Oh, okay. So if it's the last word, I know what I do want to say. So I'm not constructing a reform plan that has to yield a CBO score and coverage numbers that match it. So there's nothing in the way I think about this problem that requires me to take every population and put them into a uniform structure. I would prefer the federal government to pay the bills, because I think it's cleaner that way. And I think most of the distortions through fiscal politics of laundering money through a private system that really doesn't function very well would be better served if we could just be explicit and fund something largely through the federal government, and Medicare for All would allow that, much the way current Medicare Advantage plans do that, Medicare Advantage for All. So I'm more comfortable putting more directly into federal spending because I think it's more honest. I think the trade-off there is that you are empowering the special interests that have a particular in with the federal government to have even more influence than perhaps they currently do, and to even more medicalize social problems that should be handled outside of a medical care system. But it's a risk that in general I'm willing to take. There's a lot of things I like about the Medicare Advantage structure. I like the fact that for people who are entering, who've been entering Medicare coverage for a while, they come out of the employment-based system. Medicare Advantage plans look kind of like employer plans for a lot of people. They're pretty familiar. The old Medicare fee-for-service doesn't look like anything that most people have. Trying to wedge people into Medicare fee-for-service, I think, would be incredibly foolish. That's not what people want, and it won't serve them well. So converting to Medicare Advantage, I think, is intuitive for many people. I think one of the great advantages of Medicare Advantage is it is backstopped by Medicare fee-for-service rates, which sends a strong signal, particularly to the hospital sector, but also to physicians, that guess what? You have to be able to make money on Medicare. I can't tell you how pissed off I get when I hear from healthcare providers that Medicaid is a horrible loser, virtually nothing, that Medicare is a significant loser, and that only private insurance allows them to cover their costs. That's ridiculous. Medicare should be fairly profitable, and Medicare Advantage can be fairly profitable too. And that sort of mindset readjustment, I think, is very good. And I also like the fact that Medicare Advantage, when people do sign up for Medicare Advantage plans, they generally stay in them for many years because they don't change plans as they change employers, which they do in their working years. And as a result, Medicare Advantage plans have a little more incentive, which they honor, to invest in the longer term. They actually do a pretty good job at prevention. They do a pretty good job at looking at sort of, more than a single year of healthcare costs for their members. So I like the Medicare Advantage system. The only thing I would say in closing that troubles me about this whole conversation is that we are treating health insurance coverage as if that's health, which it isn't. And we're treating citizens as if they really don't have a role beyond consumers, which they truly do. And both parties, Republicans and Democrats, have used consumerism as a proxy for citizenship in healthcare reform now for 2 generations or more. And I think that's a horrible mistake. And I really think we would do better to honor our obligations of citizenship as well as promote our interests as consumers.
So final question, are you hopeful for positive steps moving forward now, or not really?
I am actually. I mean, I think we've spent $7 trillion that we didn't expect to spend on COVID. What's another trillion or so more to get a healthcare system might actually work in the reset? And I think that there's enough of a crisis here for people to perhaps actually pay attention. So yeah, I'm as optimistic as I could be about the future for health system redesign.
Ulrich?
I would say it could go either way. I think that the nature of democracy is we want more stuff, but we don't want to pay for it. That's the political economy of democracy in a world where you don't have fiscal constraints and you have a fiat currency. And that temptation will continue for as long as possible. So people like us obviously will do our best to try to move the system in a more fiscally responsible direction. And the fact that people just can't afford their health insurance as it goes up every year at a faster pace than wages and inflation is itself a kind of break, because BRAKE break, because there's just a certain point where it's not sustainable. So I think those factors, in a sense, hopefully weigh in the direction of a reform system and create more political pressure for a reform system. But at the same time, I think America has demonstrated for the last many decades that it prefers to increase deficits and debt rather than not. And I worry that the risk of failure is that America loses its status as the preeminent fiat currency. The fiat currency system itself is at great risk from cryptocurrencies and other technological innovations in money, in the nature of money, and that could creep up on us in a way that we aren't prepared for. And we've all grown up and lived our entire lives in a world in which the US has the dominant fiat currency. What if that isn't the case in 2040 or 2030 when demand for US treasuries start to collapse? That could be a major cataclysm that none of us have ever seen in our lifetimes. And we've seen plenty of shocking events and damaging events over the course of the next couple of years. So the danger and the risks are very, very high. But people like me and Bill and so many people who are on this call are working to try to change that outcome.
Well, with that, Ovik, Bill, thank you so much for this conversation. And Sam, I'll hand it back to you.
Yeah, Ovik and Bill, thank you so much for doing this conversation with us. It was extremely well informed, and I feel like we all learned something, and I feel like it was a really good open debate on all the issues. Again, just want to really thank you guys for participating. And then on our side, again, the Adam Smith Society, we just want to thank you all for participating, both from us at UT McCombs and also CU Boulder Lead School of Business. Again, our next event, I think, will be on gentrification, and I think that's in middle of November, which should be a really exciting event or open discussion. And so make sure you keep a lookout for that, and we can keep on talking. Thank you again for attending, and have a great night.